Hello everyone, this is Shraddha Mhatre, 5th course. Today we are going to discuss a topic about chronic kidney diseases. So chronic kidney diseases, as the name suggests, chronic is a long-term and permanent decline in the renal function, and it is usually measured by glomerular filtration rate. But in this case, with chronic kidney diseases, there are various pathophysiological processes which occurs in the body. So the chronic kidney diseases are being classified according to various stages, starting from 0 to 5 according to glomerular filtration rate. So we will discuss according to that. 0 means more than 90 ml per minute of glomerular filtration rate. 1 is 90, equal to 90 or more than that. 2 is from 60 to 89. 3, 30 to 59, 4, 15 to 29, and 5 is when glomerular filtration rate is even less than 15 ml per minute. So the pathophysiology behind this chronic kidney diseases, it's of two kinds. It's initiating mechanism and progressive mechanism. Initiating mechanism, it is really related to the specific etiological factors related to it. This etiological factor can be genetically abnormal kidney or various immune complex deposition and inflammatory cascade that happens in the kidney. So then this initiating mechanism or etiology, it causes defect, and there is second pathophysiological process that has been starting. So this second is like hyperfiltration or hypertrophy. So this in this situation, like inflammatory cascade starts, so there is release of various vasoactive hormones, cytokinins and growth factors released in the renal tubules. So this causes like sclerosis of various glomerular structure and then dropout of remaining nephrons. So it is exactly like various fibrin and collagen is released in afferent arteriole, and there causes hyaline atherosclerosis. So there is appearance like glassy appearance for afferent arteriole, and then this causes decreased blood supply to the glomerulus. This causes like ischemic changes and atrophy. So this hyaline atherosclerosis causes hyalinization of even different parts, like starting from afferent arteriole, it spreads to glomerulus, and then even till efferent arteriole, and then tubules are the last one. They also undergoes necrosis. So this causes some impairment of nephron structure and function, and when many nephrons are affected like this causes decreased glomerular filtration rate, and this is what causes end stage renal disease when many nephrons are affected. So end stage renal disease is when the glomerular filtration rate is less than 15. So then we will go to risk factors which are related to this. The main risk factor in the modern world is hypertension, diabetes mellitus, autoimmune diseases, old age, and African ancestry. Like Africans are affected more as compared to white people for chronic kidney diseases. Previous acute kidney diseases, anyone having a history of acute kidney diseases, structural abnormality, family history of any renal diseases. In this, I would like to briefly describe about diabetes mellitus. In case of diabetes mellitus, there is more glucose in the blood, so there is more filtration of this glucose into the glomerular filtration, and this causes increased like filtration of sugar, and the glomerulus work more, and in long term this damages glomerulus and thus initiates the cascade as we discussed in pathophysio, like inflammatory, then fibrin, collagen and everything. So then etiology is diabetic glomerular disease, glomerulonephritis, hypertensive nephropathy, polycystic disease and other cystic and tubulointerstitial nephropathy. If anyone is having any of these things, then it may cause chronic kidney disease. So the clinic of CKD it's divided into according to functions of the kidney. The function which is impaired, according to that clinic can be affected. So first of all, the first function is regulatory function of the kidney. So when this function of regulation is affected, there is volume overload or edema, that is excessive fluid, and then edema, and it can be visual, and then electrolyte balance. Electrolyte balance, when it is impaired, it causes hyponatremia, hyperkalemia, hyperphosphatemia, hypermagnesemia. Among all this impairment in electrolyte balance, the most important is hyperkalemia, because even a slight change in the level of potassium in the blood triggers like tachycardia and may even cause cardiac arrest. So this is like life risky. And then the third one is acidemia, abnormal regulatory function. So then we go to abnormal excretory function. As we all know, kidney excretes all those metabolic waste products. So when this is not excreted, it causes uremia. Uremia, when accumulated, gets accumulated in various different organs, even muscles, heart and everything, and which causes clinic. The first one is neuromuscular disturbance. So when neuromuscular disturbance occurs, it causes fatigue, sleep disorders, headaches, seizure, and severe cases common. But when cardiovascular disturbance occurs, initially it even further causes hypertension, pulmonary edema, and in severe cases pericarditis. Encephalopathy occurs, dermatological abnormality also occurs, and this involves hyperpigmentation, pruritus, and ecchymosis. So abnormal endocrine function, kidney, one of the main function is also endocrine. When kidney releases erythropoietin. Erythropoietin is important for release of RBCs from red bone marrow. So due to this abnormality, there is no release of RBC from the kidney, and other than that, RBCs can't survive in uremic environment, which occurs because of impaired excretory function. So in anemia, the symptoms which can be like fatigue, then angina, heart failure, reduced exercise tolerance, decreased cognition and mental acuity, and also host defense against fighting against infection is also impaired. Then we will discuss about abnormal metabolic function. Very few people know kidney has a metabolic function also, and this function is production of like activation of vitamin D. So vitamin D, the precursor of vitamin D, is activated into active vitamin D by the kidney, that too specially the cells of proximal convoluted tubule. So this vitamin D is not formed. This vitamin D helps in absorption of calcium from gastrointestinal tract, and then this calcium then triggers a parathyroid hormone. When this calcium is less, parathyroid hormone is released more, causing more release of calcium and phosphate. This causes hyperphosphatemia and also secondary hyperparathyroidism. Those are included in this chronic renal diseases. And other than the function, there is also bipedal edema. In bipedal edema, it's like more and more albumin is excreted due to loss of renal function, like loss of nephron activity. So more and more albumin is excreted, so less albumin is left in intravascular spaces, and albumin as a structure is a sponge-like. It helps in maintaining more water or more fluid inside the intravascular space. So because of loss of albumin, more and more water is excreted into other areas of the body, causing bipedal edema, and it may also cause other edema other than bipedal edema, but the mechanism is related to the function of albumin. So now we have discussed everything about clinic, and so last and not the least is treatment. So treatment, it's like as we do for every pathologist, first should be conservative and then it should be surgical. So for conservative, first of all, it is protein restriction, controlling blood pressure, proteinuria, and then controlling blood glucose. So even reducing intraglomerular hypertension is very important because this increases the cascade which causes chronic kidney diseases. And we even have to protect the remaining viable nephrons. For reducing intraglomerular hypertension, the best possible drug is ACE inhibitor and angiotensin receptor blocker. Other than just reducing hypertension of glomerulus, it also decreases the overall systemic hypertension. And very important is, in this case, doctor should remember about nephrotoxic drugs. So we should avoid nephrotoxic drugs like non-steroidal anti-inflammatory drugs, antibiotics like amikacin, gentamicin, and that's it for conservative treatment. So now we come to treatment, which is very important and most popular for chronic kidney diseases. There are three main treatment. First starts with renal replacement therapy, and then it's hemodialysis, and last is kidney transplant. First one, renal replacement therapy, we give this mainly when glomerular filtration rate is from 15 to 29 ml per minute. That is the fourth stage as we classified. So this we give renal replacement therapy mainly according to symptoms like pericarditis, encephalopathy, anorexia or malnutrition. When we see these things in patient along with decreased glomerular filtration rate, then we give renal replacement therapy. Then when there is uremic syndrome, we go for dialysis. Dialysis, we have a mnemonic here, AEIOU. A stands for acidemia, E for electrolyte abnormality, especially when hyperkalemia with ECG changes, that is hyperacute TB. Then I for intoxication, O for volume overload, U for uremia, pericarditis, encephalopathy, severe bleeding, as in case of severe uremia. So dialysis usually we do in fourth stage or fifth stage, but mainly we refer to these symptoms. And when renal replacement therapy and dialysis does not work and it's already end stage renal disease, when glomerular filtration is even less than 15 ml per minute, or when all this other treatment doesn't work, there is last option as renal transplant, and there have been really nice outcome after renal transplant which has increased survival rate of the patient. So that's it for today. Thank you so much. If you like this video, put a thumbs up and share it as much as you can. Thank you.
My name is Ruben Gompalan and this is Webzmedlectures.